This is a whistle-stop description of an open repair of a right-sided inguinal hernia with mesh. Landmarks are identified with the pubic tubercle medially at the top of the screen, anterior superior iliac spine laterally at the bottom of the screen. A line joining these signifies the inguinal ligament. The skin incision is made parallel to this line, cephalad, initially through the pink layer, which is the skin, which is then retracted, dropping onto the subcutaneous fat. Subcutaneous fat is opened with continued dissection down onto the roof of the inguinal canal, which is formed by the external oblique muscle. The medial incision is extended so that the pubic tubercle is palpable on the model. The external oblique is opened, and then scissors used to open it all the way to the superficial ring medially at the top of the screen. This is then retracted. This reveals the spermatic cord in the centre of the screen, which is normally adherent to other structures or tissues within the inguinal canal. This is mobilised using fingers at the level of the pubic tubercle, and then it can be retracted with a sloop or a hernia ring. The posterior wall is here revealed, along with a direct defect, signified by yellow sponge bulging through the purple layer. This is closed with interrupted vicral sutures and plicated to reinforce the posterior wall. Once the posterior wall is reinforced, the cord is opened to identify the indirect sac. This is normally adherent to other structures within the cord, including the vessels and the vas deferens. Clips are applied prior to opening the sac to check if the sac is empty. Once this is confirmed, the sac is closed with a vicryl stitch. The excess sac is excised and the stump of the sac is reduced through the deep ring. We're now ready to secure the mesh. The mesh is cut to size, and trouser leg are cut in the mesh, which will serve to go around the spermatic cord and recreate the deep ring. The mesh is secured to the pubic tubercle with a proline suture. And the mesh is then laid so that it sits alongside the inguinal ligament at its inferior edge. The same proline suture is then used to secure the inferior edge of the mesh to the inguinal ligament using a continuous suture. Interrupted sutures can be used if preferred. When we get about halfway down, the cord structures are then retracted cephalad, and the trouser legs of the mesh are secured around the spermatic cord, which will help us create the deep ring. We then continue to secure the inferior edge of the mesh to the inguinal ligament beyond the deep ring. The trouser legs on the model have been cut slightly short. Once we've finished securing the mesh to the inguinal ligament, we then use a couple of proline sutures to recreate the deep ring by stitching the trouser legs of the mesh together. The cord is then retracted caudally again, and the mesh is laid flat, and vicryl tacking sutures are used to secure the mesh to the posterior wall. Excess mesh is tucked under the external oblique layers to keep it nice and flat. The repair is now complete, and we just have to close. The external oblique is closed with a continuous locking vicryl stitch, leaving the superficial ring at the medial extent open. Once the external oblique is closed, then the rest of the wound can be closed in layers. I would normally use some interrupted vicryl to the fat, followed by a absorbable subcuticular stitch to the skin, thus completing the inguinal hernia repair. Longer description will be posted at a later stage.